Welcome to the Taylor Method for Pain-Free Living, a podcast that features enlightening conversations with experts in the medical field that helps to improve the health and well-being of those suffering from chronic pain due to injury. Learn from leading authorities the questions you should be asking to experience pain-free living. Hosted by father and son, Dr. Derek Taylor and Dr. Hudson Taylor, and joined by industry professionals in the health field, including doctors of integrative medicine and personal injury attorneys. Enjoy well-rounded and informative conversations to help you get out of pain while achieving optimal wellness. Dr. Derek Taylor and Dr. Hudson Taylor are the doctors of Taylor Chiropractic and Laser Center in Florida and California. Both father and son duo have earned respect and a solid reputation for successfully helping people transform their lives by assisting them to discover the hidden causes of their painful health challenges, leading them to experience the resolution of their problems using the Taylor Method. Tune in each week to learn about the Taylor Method, Dr. Taylor's proprietary technology that looks at the whole person and identifies the root cause of pain while facilitating natural healing and helps to restore the body to optimal wellness without using drug injections or surgery.
Welcome to our show. Our guest today is Dr. Leia Rispoli. Dr. Leia Rispoli of Disc Sports and Spine Center is a double board certified interventional pain management specialist and physiatrist. She embraces an empathetic approach and a keen ability to listen to her patients while delivering exceptional care. She employs non-surgical interventions and evidence-based treatments, and she specializes specifically in patient populations, which typically include those with chronic or acute pain of the low back, neck, head, peripheral joints, and pelvic region as well. So Dr. Rispoli, it's a pleasure and an honor to have you this morning. I wanted to ask you, what specifically drew you to interventional pain management and just specializing in that area?
Hi. Yeah. Well, first off, thank you for having me on your podcast. I really appreciate it. It's an honor to be here as well. And thank you for that lovely introduction. To answer your question, so I did my residency in physical medicine rehab, which also is known as physiatry. And that gives you a really good base training in musculoskeletal and neuromuscular dysfunction. So you get a really good idea of anatomy from those perspectives, and you have the option to kind of go into spinal cord injury, brain injury, sports medicine, pain medicine. And initially I had really been interested in sports medicine, being an athlete growing up and collegiately, but the pain medicine world kind of kept drawing me, mostly because of the interventions. So we do a lot of procedures with our hands, which I like the technical aspects of, doing a lot of injections and different types of procedures, but also pain patients are super complicated. They usually have a lot going on emotionally because of suffering from years of chronic debilitating pain. And I felt that I excelled in being able to listen and validate people through their difficulties through suffering from chronic pain. And it's something that I just felt very naturally drawn to. So it became a very easy decision for me to delve into further training and do a pain fellowship after doing physiatry residency.
I love the fact that you have this hands-on musculoskeletal approach with your being a physiatrist, and then also combining that with the medicine aspect of it with pain management. That's a real unique breed. I have never come across a doctor that does both of those. Tell me how that interplays in your practice and how that, niches you differently compared to any other pain management specialist that I know.
Yeah. So you can do pain management from anesthesia, from physiatry, from family medicine, a variety of base trainings, but a lot of us come from physiatry, which, as I said, gives us that musculoskeletal hands-on approach where we tend to look at physical function and disabling function. So people that come in with some sort of deficit whether it be through injury, inborn congenital abnormality, or a stroke, or an injury, a spinal cord injury. So we're taught to have that type of scope, looking at a patient and seeing what is disabling their function and how do we maximize their quality of life. So that, I think, in my mind, is a great introduction on how to treat a pain patient. You look them as a whole,
awesome.
And then you're able to kind of delve into how to treat some of the sources of their pain with the interventional techniques that we've learned. So that's, to answer your question, that's kind of the scope of the practice.
So you actually do a hands-on approach yourself. Do you yourself work on the patient if they have, let's say, for example, pelvic pain? Are you the one that's or do you have one of your assistants doing that? How does that work out?
So with pelvic pain, it's a little bit of a different scope, it's a little different approach. That came with training from physiatry and then further clinical experience through just kind of getting into pelvic pain, because there's not many pain doctors that see that patient population and they're open to seeing that patient population, because that's an even more complex population. Male and female pelvic pain is kind of hush, and people are very uncomfortable discussing it. Patients too, because they've seen their providers, they've seen their gynecologists and their urologists, and they're embarrassed, and it's a tough, intimate subject to discuss because it usually involves urinary, bowel, or sexual dysfunction. So to me, that is just being able to understand some of the common problems and being able to discuss it openly and comfortably with patients already is a huge step in the proper treatment and approach to those patients.
Mm-hmm. So how do you handle those pain? I mean, what is a common cause of pelvic pain for men and women? And is it the same etiology for the different sexes, or completely different based upon being female or male?
That's a good question. And it's a huge answer I could go into for hours. It's a great discussion, and that's probably deserving of a whole nother session. But in briefly, pelvic dysfunction is just way more complex than we want to assume. A lot of primary providers like the gynecologist or the urologist, as long as it's not clear dysfunction in one of the anatomical aspects of, the urinary or bowel or, pelvic anatomy, then patients are typically labeled with general diagnoses, interstitial cystitis or chronic pelvic pain or chronic prostatitis. And these patients end up getting these just repetitive treatments and still having a lot of pain. So, to summarize kind of where I'm going, there's a lot that we don't understand about pelvic pain, and it's very complicated. It's not just one diagnosis. It usually has typical involvement of nerve, muscle, and then a little bit of psychosocial and even psychosomatic aspects of the pain. Because once a patient is suffering for so long, because a lot of these patients come to me after being, in pain and discomfort for 10 years. A lot of it ends up being centralized pain, sort of stored in the central nervous system, where it's very hard to turn off a sense of like a hypersensitivity, where anything flares them and they get discomfort or difficulty urinating or difficult with sexual function or difficult with bowel movements. And it becomes a really complex thing to treat, but it's just so common, and it's so sad because a lot of patients don't find the right provider to help guide or treat or even validate their symptoms for quite some time.
Do you have a set method for diagnosing a complex patient like that in your mind, or just with your diagnostic procedures? Do you have a set method or process that you take each patient through?
Yes, definitely. For now, and it's ever evolving. And that's the thing about medicine. I'm sure you guys experience this too. My algorithm today may change slightly over the next couple of years as I learn more through different patients and seeing more complicated cases. But as of now, and it's a really team approach. I have a very strong team that's not just me as a provider. I have my really excellent sources of pelvic floor physical therapists that I rely on, really, because they are the intimate, consistent routine evaluators of being able to not only examine a patient and spend a long time with them and a whole session with them, but repetitive sessions with them and see, whether or not they're improving from certain, myofascial release techniques, or, are able to identify certain muscle groups that are really angry or stubborn, and are able to help kind of hone in on where we think the source is coming from. And then, I work with the pelvic floor therapist to then offer some diagnostic tools to help identify some sources if it seems to be a confusing picture. Because a common diagnosis that patients come to me with is a pudendal neuralgia, a pudendal nerve coming off the sacral nerve roots that have a certain distribution of sensory and motor function. Patients go on the internet and then they say, oh, I have pudendal neuralgia. And a lot of times they don't. So, sometimes we'll do certain diagnostic tools, different trigger point injections or Botox injections or nerve blocks to kind of either confirm or debunk something, that they think they have.
Mm-hmm. How do you balance out, starting them with a therapy approach, a physical therapy or a pelvic therapist? How do you balance out the more therapeutic approach or a physical therapy approach with the injection, more interventional approach? Do you just immediately start them off with the physical therapist first, or in some cases, do you go straight to more interventional? What does that look like?
That's a good question. And I'd say both in pelvic floor and in spine, which I see probably a majority. I'd say my practice is 70% spine, 30% pelvic. But, I'm pretty conservative. So I usually don't off the bat offer an injection or intervention unless a patient has gone through the conservative, has seen a chiropractor or seen a physical therapist and had, conservative treatments. Because a lot of times these patients, as get better with just therapy and chiropractic care. So, I give them that chance before injecting. However, there are, exceptions to that, the patients that come with a really acute disc herniation and are really suffering and can't even tolerate any hands-on therapy. Those patients might deserve an intervention or a medication in combination with treatments.
Yeah. Dr. Taylor, one thing real quick. Some of the most difficult patients that we've seen are the ones with the significant disc herniation that have damaged the nerve, and it's just we have to be on them, treating them pretty frequently to get that to go away. But once a nerve is damaged, it takes some time. Eventually, it gets better, but it's agonizing.
Yeah.
So
super debilitating.
So to hear that this is your specialty, this is just good for me to know, because those are the patients that I've been thinking about as of lately. It's like, how do you immediately, how can we immediately take care of that naturally? But if not that, who can I send them to, also for immediate relief?
And also because I'm a firm believer in chiro and PT also in combination with what I offer. So I tell patients it's not one or the other. It takes part in, some patients really sometimes they just want an injection and hope they just get better. And I'm like, it doesn't work like that. You got to put in some work too. You got to work with a therapist, you got to work with a chiropractor, and put in like weeks of work, because it's not just a quick fix. So, and then the whole idea of preventing this from happening again and further destruction and finding out ways to correct and maybe, prevent repetitive injury is a huge aspect of the patient's recovery and rehab.
What's been your success with helping females that have delivered 1, 2, 3, even more children, and now they're having all these pelvic floor dysfunctions and issues, and then also, let's just start with that, because I have another question in regards to that as well. Can you comment on that? Because there's so many of our listeners out there that are in this category, right?
Absolutely. And they're not alone. And that's the thing, like, especially women and even men, it's an embarrassing and it's a hard topic to bring up with your provider, and you don't know who to talk to. So, for all the women out there that are, postpartum from several kids, or all the men out there that have had, pelvic issues that have been dismissed by their other doctors, there are other resources out there for just some answers and some, more options for treatment. And it's an up and coming world of pelvic pain treatment algorithms with pelvic physical therapists and pain specialists that have experience treating this type of ailment. And there's just way more resources than I think people realize, more than being able to just see 1 or 2 doctors like their gynecologist or urologist that don't have answers for them. But typically, sorry, to answer your question, it's, women that have had several kids suffer from just muscle loss, both core, glute, and pelvic floor. And with each kid, and it becomes harder, obviously, with more kids. I have two myself now, to keep up with staying active and fit, and especially women, like the Florida, California population. There's a lot of fit people here that are used to exercising on a daily basis. But obviously, when you have kids and you have no time, keeping up with certain exercises really has the body suffer. Your spine starts to, and it comes with aging too, but your spine, the pelvic floor weakness, a lot of people develop a lot of incontinence, urinary incontinence. So, that's where sooner than later, patients should consider seeing a good quality pelvic floor physical therapist, because it's not just Kegels. It's not just, doing just squats every day. There's a lot about the anatomy that patients can learn from pelvic floor physical therapists about their own body, and ways to kind of maintain and re-strengthen all of the muscles that support the pelvic floor.
Mm-hmm. Yeah, interesting. And then can you comment on episiotomies? We've seen patients with pelvic pain and the connection between episiotomies, or they tear in the scar tissue that's created in there, in that region, and how that affects that entire area. Have you any thoughts on that in regards to that?
It's so common. And episiotomies obviously are used in the moment to help deliver a baby, but the mother suffers afterwards, and then the scar tissue. And then, a lot of patients can develop either painful sexual habits after that, or just pain in general from prolonged sitting. And again, this comes, it's retraining the body and working with the scar tissue, just like any wound, any kind of surgery and repair. Scar tissue that develops usually does better with consistent scar tissue mobilization. So as soon as you have that 6-week postpartum follow-up with your OB and are cleared for exercise, and therapy, you should be seeking pelvic floor therapist to work on all the aspects of your pregnancy, labor, delivery, and then, address these things earlier than later, because a lot of women, including myself, you get so busy with your new kids that you forget to take care of yourself. And then 5-10 years down the road, you've been suffering and ignoring it for years, and are really at your wit's end, and then have all this cleanup to do. So I encourage patients to seek help early.
Mm-hmm. Now, what are the most common causes of pelvic floor issues with males in your experience?
Yeah, in my experience, it's a combination of things. A lot can do with patients that either develop some sort of prostatitis in their history, where they develop a slight infection either in their prostate or even in their epididymis, and it becomes either recurrent. It's kind of like a recurrent UTI population in females, and with that comes excess pain, and pain with urination, and pain with certain functions. We see that a lot. We see a lot of pelvic pain issues with males that have had history of hernia repair. A lot of males, with really a lot of various backgrounds. It's so hard to tell you what the most common is, because I've seen it all. And some even have like some remote trauma to their sacrum, either like a fall, a sports injury where they hurt their sacrum, or not so much men, but women, horseback riders that have a lot of gluteal trauma or coccyx trauma. So, we see it all.
Right. And so that's interesting. I mean, you have these males that the connection between the lumbosacral area and pelvic floor issues, and how many of these people are playing sports, or they grew up playing sports and they've taken a fall on their back and they've ignored it. And now it's coming to bite them later on when they're in their 40s, 50s, 60s. And then the question is the connection. Have you seen an association between pelvic floor dysfunction and erectile dysfunction?
Yeah, absolutely. I mean, that's, I didn't want to come out and say all of that, but because it's something that is a whole nother topic. But yes, pelvic floor almost all the time. And patients aren't always forward about talking about this initially. But that's why, you need an educated provider, like, letting patients feel comfortable opening up about this kind of stuff. But sexual dysfunction almost always comes with pelvic floor dysfunction. The whole sexual function involves all the nerves leading off of our sacrum and our autonomic nervous system is typically involved with pelvic floor dysfunction too, especially pelvic floor pain that's been present for several years. So, definitely a huge urinary, bowel, and sexual dysfunction are almost always a part of a quote general pelvic floor patient that comes to see me.
And that's not the only thing you work with. You also work with a lot of spinal conditions. A lot of our listeners, they have nowhere to turn when it comes to spinal stenosis. So can you talk about that in your experience with working with patients with either lumbar spinal stenosis or cervical spinal stenosis? Or
yeah, definitely. That's probably number one diagnosis I see in my office on a daily basis, just because it's sort of inevitable. Our spine deteriorates as we age, some people faster than others, and we can do some things to help prevent, the degeneration of our discs. But, inevitably when you turn a certain age, these things happen. It's like getting wrinkles, right? Treatment algorithm or treatment plan for a lot of these patients mostly depends on the clinical symptoms they present with. And I usually am conservative with my treatment management. I usually start with therapy, chiropractic care, acupuncture, really the conservative things in patients so that they try, the least invasive before moving to the next steps. But, most of what I offer after they've completed and they're still suffering is either injection therapies like epidurals. And then, there's a whole new gauntlet of different type of pain procedures that can help spinal stenosis patients that are a little bit newer on the market, but the studies really support their effectiveness. And those includes Vertiflex, spinal cord stimulation, and those are very specific pain procedures that really can help certain patient populations that have failed conservative things that aren't candidates for surgery, because surgery is always the final step because it's irreversible and is the most invasive and requires quite a recovery. But that's where the conservative team, including the therapy providers, the chiropractic cares, the pain providers, can offer as much as we can before patients need to take that step.
What percentage of your patients would you say are coming to you from a failed spinal stenosis surgery that they were promised? So often I hear they just think that the surgery is going to be the cure-all end-all that's going to resolve their issue, and then sometimes it ends up making it more complicated, and now the damage has been done, right?
Yep.
And so do you see quite a few patients that are in that category?
So many, countless. Yeah, and that's the thing. What part of what we provide, you guys and I, is educating patients, because a lot can go on the internet and say, oh, surgery looks like it was great for these people. And then on the other hand, some people are like so scared of surgery when, surgery might actually be effective for them. So, it's a complex, deep topic, because you're right. A lot of spinal stenosis patients that end up getting kind of fused or a lot of hardware put in there, I'd say 50-50 end up being 50% end up being better. And then that better is for how many years, because a lot of these patients end up coming back in my office a couple of years later, because what we see a lot is something called adjacent segment disease. So you fuse, two vertebrae that are completely stenosed. And what ends up happening is the levels above and below become degraded faster, just because of the sheer physics of the forces that now have to put more burden on the levels above and below from two vertebrae turning into one. So we see that all the time. And it's like, we have to educate patients on why that happened, and that, surgery isn't always the first answer because of that reason, because it can develop more, issues, or it might fix your immediate problem, but, lead to other problems later. So, and the good surgeons know this too, and they educate patients, so it's really good as a pain provider to have the good quality and conservative surgeons in your back pocket too, that are on the same page as you.
Mm-hmm. Yeah. So had they come to you before the surgery, isn't that a better option? Because trying to take care, because how much more difficult is it for you to correct a failed surgery compared to somebody who has not had that scar tissue or hardware put in there? And, it's a lot easier to correct, isn't it?
Yep. And, you know, it's, that's why, you know, we hope that the surgeon at least considers sending a patient to a pain provider or a therapist or a chiropractic doctor, because, you know, if it was my family member, I would say, please try all these things before getting, you know,
surgery is the last resort, right?
Exactly. And, you know, for good reason, because we see it, we see all the outcomes, and, you know, it's, in some cases it can help. And there are certain cases that surgery is needed. You know, if somebody comes in with a complete, pinched nerve with weakness, or you know, someone comes in, you know, myelopathic with loss of sensory or motor function, you know, those people require surgery no matter what, and, you know, still deal with the after side effects of post-surgical issues. But you know, the patients that are in the gray, that are like, I want surgery because it's going to be fixed, it's on the providers to help educate patients, say, look, it might not fix you, it might not give you pain-free life, it may help a little bit, but here's the reality of what may happen. And that's, I think, as a provider, our due diligence to the population, and our honesty in how to treat patients.
So what advice would you give to the listeners who are you know, maybe who are in severe pain, who are considering the option of surgery, and who have been told by multiple doctors, hey, you're going to probably need surgery? What advice would you give them if they were to be, you know, listening now?
So I would say just make sure that they see several opinions. I think there's no harm in hearing one or two surgeons, even three surgeons' perspective, because, you know, medicine is not black and white. It's an art, and there's different perspectives. And I think the more a patient can be educated in what options they have, the more, you know, the better the outcomes. Because, you know, the worst thing is to hear a patient say, I was only told I needed this, and then I find out 5 years later that I didn't really need it, and now I'm in worse shape. You know, it's sad to hear it, because you're right. You know, it becomes harder to treat pain when you've already had several, you know, surgeries in the past, and your options are really limited. So that's kind of my advice. Seek several opinions, and know that there are options, you know, by talking to several providers, and, you know, surgery isn't always the answer, and that, unfortunately, you know, our spine ages, and, you know, having a completely pain-free life might not be obtainable. So, you know, consider that it's you want to have the least amount of pain, and the best quality of life should be the goal. And I tell patients that all the time, because I don't want them to have unrealistic expectations. So somebody in their 70s or 60s that has, you know, severe arthritis at several levels, you know, I'm not going to give you 100% pain relief all the time, but I'm going to teach you ways to modify your life so that your pain is minimal and you have more days that are good than bad. And then if patients can understand that and still live a good quality of life, then we're all on the same page, and they seem to be pretty happy.
I think that's really good advice. I mean, so many people, they neglect for decades, they're neglecting their musculoskeletal complaints. They're ignoring them, right? And finally, the body starts to scream at them so much, hey, you got to do something about this. They go to do something, and, you know, the damage has been done. The neglect has been there. You can't undo, you know, a phase 3 spinal degeneration. You can't get that back to phase 1 again. I mean, if they've ignored it for that long, I think what you just said is brilliant. You know, you're going to live with some level of pain. It's a matter of how you can minimize that as much as possible and increase the quality of your life.
Yep.
And I also love the advice you gave us. Yeah, we always tell people, hey, don't just listen to what I have to say and take that as the truth. Hear what we have to say. Go get your opinion with your medical doctor and others, and see what resonates with you, right? You know, there's so many times people, they're a failed surgery, and, oh, I just did what the doctor told me, but I wish I hadn't done that. They're thinking about it after the fact that the damage has been done, rather than doing their homework and doing their due diligence beforehand and making that decision before they made this major life altering decision.
Exactly.
And, you know, so I think that's really good. And just, again, it's that team approach And that's why we have these shows. We want people to have other exposed to other methods, other approaches, because as you know, not everybody's going to be the best fit for your office, right? You know, we're not there for everybody. Certain people we're gonna have greater success with. You know how to identify those people. You know how to say, hey, we have a really high success rate. We're going to help you with this. This is a great option. They see that confidence, that certainty in you, then, you know, it's going to make them, helping them make their decision. So what is that one thing that you do better than anybody else on the planet, Dr. Rispoli, that if you were to say, hey, for a certain condition, we have such a high success rate, we nailed this, we really niched down so we can, what would you say that is in your practice, since you do so many different things?
Oh, that's tough. I mean, I would say spine. We're just good at spine. I mean, just because we see it so much, and I work so closely with the surgeon, so I have seen such a variety of presentations, and you know, seen everything that I feel, and you know, it's constant learning. So everything is all relative, right? Because I'm still young, still early in practice, but you know, I feel we have such a good team supporting my practice that I feel very confident in being able to handle whatever walks through the door that's spine related. And that being said, pelvic feels just right behind there too, you know, pelvic pain. So those two categories feel like anything can walk through the door and we'll take good care of you. But I think overall as a provider, like I think the one thing that I do that separates me probably from other pain doctors, especially in the LA area, is that I listen. And I think I give a little bit more of a caretaker approach than a lot of maybe other doctors do in the area. And I think patients really resonate with that, you know, being able to just be heard and listened and feel taken care of. And pain patients need that, you know, they want to feel like they're safe and they're going to be taken care of, and everything that I can do I'll give my best efforts towards. And you know, I think that's more rare, unfortunately, in today's day and age with a lot of doctors. They're so rushed, or you're just a number, or, you know, they don't feel like patients don't feel like they're really taken care of.
And that's so well said. And from a clinical point of view too, how many times have we been able to really get down to the root cause of their problem because you did take the time to listen? So many times they don't take a real thorough history. Doctors don't take a thorough history, and they're missing some major clues that we hear in the history that are pointing directly to the area of complaint, directly to what's the diagnosis, and directly to what you need to do in order to resolve that problem. But that's not going to happen if you're not listening. You have to be a good listener. And we're so glad that we found a doctor in our area, such as yourself, that really takes the time to listen to patients. This has been a fascinating show. What do you think, Dr. Hudson?
Oh my goodness, absolutely. One thing I want to say as well, what you said just kind of earlier about, hey, you know, here's how much we're going to be able to help you. This is the pain that you may, you know, still be with for a while. It may not be possible to achieve, you know, a pain-free life, but it's like, you know, differentiating that point and separating, okay, here's what we can really, really help you with. And then here's what may still be there. But if you do these things, then your overall quality of life is going to really improve. And yet still being realistic and setting those expectations for the patients because you genuinely listen and care. I mean, that's a really powerful way to really take care of a patient well and builds trust. And it's inspiring for me to hear that. It's kind of a great philosophy there. So thank you for teaching, for sharing that with us.
Yeah. And thank you guys, because I know you guys take care of so many patients, and, you know, chiropractors have such a powerful role too in patient care, because, you know, patients go and see you more often than they see their pain provider. So, you know, you develop a different type of relationship with them and have this more effective continuity. So I appreciate all the work that you guys do and the care you take with patients. So it's a team approach. So appreciate you guys.
Thank you. Well, you've been listening to the Taylor Method for Pain-Free Living. Our guest today was Dr. Leia Rispoli in Santa Monica. Doc, how can our listeners get a hold of you? What can you give us your contact information?
Yeah, absolutely. Well, the easiest way is just to go on my website, which is leiarispolimd.com, LeiaRispolimd.com. You can Google my name. It should pop up real quick. And then that's the best way to kind of get in touch with my office, make an appointment, or even just call for a telemed consultation, which, telemed's been great because I can talk to patients, from wherever they are. So.
Yeah, great. What's the telephone number they can call you at?
310-405-0595.
Great. Well, hey, thanks so much for being our guest today. It's been a great show. And we, pay patients with that pelvic pain that's been stubborn, or spinal stenosis and even other conditions. They're looking for pain management. Doctor, you look like our go-to gal for that. So thanks so much. Guys. This has been a great time.
Yeah,
and
absolutely.
I appreciate you guys. Thank you for having me.
Yeah, thank you.
Thank you for listening to the Taylor Method for Pain-Free Living podcast. For more information about the Taylor Method and how you can find lasting pain relief, visit www.drderektaylor.com. That's www.drderektaylor.com.